Great. So good afternoon. Thank you everyone who is joining us here today to listen to this webinar. My name is Geraldine. I am an undergraduate student majoring in psychology, and I will be your facilitator for today. Today we are so grateful to have Dr. Mark Relier. A little bit about Mark is that he is a community psychologist and statistician at the VA Connecticut healthcare system and associate research scientist at Yale School of Medicine. His focus is on understanding how to prevent sexual assault and harassment and improve outcomes for survivors. Dr. Relier's current research seeks to understand the frequency, consequences, and predictors of patients' harassment towards staff and other patients within healthcare systems, and the utility of bystander intervention training to address patient harassment. So with that, please give Mark a warm welcome, and we will begin soon.
Thank you, everyone, for joining today.
And just a little bit of acknowledgements before Mark begins. This presentation was presented for the New England MHTC under a cooperative agreement with SAMHSA. All the material here is in the public domain and may be reproduced or copied without permission from SAMHSA or the authors. The opinions expressed herein are the views of the moderator and the panelists and do not reflect the official positions of the Department of Health and Human Services or SAMHSA. The MHTC network uses affirming, respectful, and recovery-oriented language in all activities. This language includes strength-based and hopeful, person first and free of labels, respectful, clear, and understandable, to name a few. So that Mark can take it away now.
Thank you, Geraldine, for the introduction. As Geraldine said, my name is Mark Relier. I'm a community psychologist. My background has been in research and evaluation in sexual assault, sexual harassment. And today I'm going to be talking about both helpful and harmful responses that people are commonly given, or that we commonly give when people disclose sexual assault. So to provide an overview, I'm going to first go over some reactions that are common when women receive when disclosing sexual assault, factors that make receiving harmful reactions more likely, those consequences of receiving those reactions on coping and mental health, and lastly, hope to give some guidelines for some supportive responses to provide either as a community member, a friend, a family member, or as a mental health or social service professional. First, I want to give some disclaimers. All groups of people experience sexual assault. However, what we know about social reactions in the research tends to primarily come from studies with college or community samples of women, usually younger to middle-aged women who are either white or Black. And we know that social reactions, like any social behavior, are affected by historical, situational, contextual, cultural factors, in this case also linguistic factors. So we might be missing some reactions that are experienced by understudied groups, including men, Asian Americans who tend to be underrepresented in this literature, LGBTQ+, and people who are older. And lastly, I want to say that we know that people who experience sexual assault commonly are experiencing other forms of interpersonal violence, either in the past or currently. So either currently in a relationship where they're experiencing intimate partner violence, or have experienced other traumas in the past. Yet the research is often involved on their disclosures to their sexual assault specifically, without talking about the kind of context under which they may have provided in talking around their sexual assault. So for part one, go over reactions to disclosing sexual assault. And I'll say that most women who disclose sexual assault disclose to informal responders, such as friends or family members, rather than formal providers, such as mental health service providers. And that's for a variety of reasons. Women report feeling hesitant to seek help from these formal social systems due to beliefs that they aren't worthy of services if their experience wasn't a stereotypical example of rape. And this kind of goes into both kind of internally not feeling that they're worthy for services, as well as concerns that if they go to services that they won't qualify for services, or that they'll be dismissed if they don't feel that their experience was something that fits a more stereotypical narrative. Secondly, the worry that systems can't help or protect them or won't be able to do much, or that they won't be believed or cared about. And lastly, the word seeking help could intensify painful feelings beyond what they currently feel that they either want to experience right now or want to cope with. So they feel kind of cons outweigh the pros. And the reason these are all important to think about is that when people come in and start to disclose, even if they are willing to disclose, they might still have a lot of these fears that people commonly experience. And so we want to make sure that we're thinking about how do we provide reactions that counter some of these fears that people may not be explicitly mentioning. So most of what we know about the reactions that people provide come from a measure by Professor Sarah Ullman, who I worked with at the University of Illinois at Chicago when I was in graduate school, which is the Social Reactions Questionnaire, which measures different positive and negative reactions that people receive when they disclose sexual assault. It's also been used now to measure reactions for a variety of interpersonal forms of violence, such as harassment or intimate partner violence. So the Social Reactions Questionnaire, it measures positive reactions such as belief and other forms of emotional support, and tangible aid and other types of informational support. It also measures different negative reactions, and these include both reactions that turn against the survivor. So the most common one you commonly hear about talked about is victim blame, or treating differently or stigmatizing the survivor, or controlling reactions that infantilize, so making someone feel like a child. And these are really, when we talk about negative reactions, a lot of times these are the reactions that people commonly think about because they're more hostile reactions of dismissing the survivor. The negative reactions also include what we've termed unsupportive acknowledgement. So the reactions that do acknowledge the assault, and it's possible that people may even be attempting to help with these and don't perceive themselves to be giving negative reactions. And these include egocentric reactions, such as the support provider getting so upset that the survivor feel like they needed to take care of them, going into their own kind of histories, sharing so much that the survivor felt like they kind of lost, that the focus was taken off their disclosure. Distraction, which is kind of trying to distract people with other things, or directly telling them to move on, to try not to think about it. Or controlling reactions, a little differently than controlling actions above. These aren't necessarily infantilizing ones, but ones that still make decisions that don't support the survivor's autonomy. So kind of making decisions for them. So how common are these reactions? So we know from cross studies that almost all women who disclose sexual assault report receiving both positive and negative reactions. So it's fairly uncommon that people only experience either positive or just negative reactions. And even those ones that kind of overtly turn against survivors, such as victim blame, they're less common, but they're still experienced by almost 80% of women. So this is something to keep in mind, that most people are experiencing a wide variety of both positive and negative reactions. And these reactions, including the negative ones, don't just come from kind of informal providers or the police, which is where a lot of people think about when they think about negative reactions. They also come from mental health providers as well, and friends and family. So talk about what are some factors that make receiving harmful reactions more likely, or what are the factors that also make us more likely to give harmful reactions? So we know the women are more likely to receive negative reactions if they already have some type of disadvantage or greater distress in some way, or have faced inequality in various ways, including Black and Hispanic women, bisexual women, women with less education, or who have more extensive trauma histories, more severe assaults, use of or used alcohol prior to the assault, and those that disclose to both formal and informal responders, because those people in general have disclosed to more people, and the more people they disclose to, some of those reactions will be negative. But also we know that unfortunately people are more likely to receive negative reactions if they are already personally engaging in maladaptive coping, such as using substances, blaming themselves, using avoidance, or if they have greater psychopathology, such as PTSD symptoms. And this is really important for a couple reasons. One, unfortunately, these are usually the people that we hope that we're going to provide the best reactions to. These are the people who we hope that are going to receive great support because they currently are experiencing higher rates of distress and they need support. But also because we know that people are, if they come in and they're giving these maladaptive kind of coping responses, it's something to think about in terms of our own reactions to them. Because we know that people report that when someone comes to them and is engaging in a lot of these, it's more difficult for them to provide support. They're not sure what to do when someone comes to them and they have a lot going on, when they disclose that that's not what happened, but they're using a lot of substances, for instance. If you're a mental health provider, it's difficult to know what you're going to focus on them at that point. And people end up getting more negative reactions. So what are the consequences of receiving these reactions for coping and mental health? We know in a recent meta-analysis by Dworkin and colleagues, and then across a lot of different studies, that negative reactions are associated with a lot of negative outcomes, both cross-sectionally and over time, including psychological symptoms such as PTSD or depression or anxiety, substance use and abuse, general distress and self-blame, social withdrawal, decreased sexual assertiveness. So that's decreased levels of assertiveness and communication around sex and relationships, maladaptive coping skills, which we just kind of talked about, and even re-victimization. Unfortunately, positive reactions are generally not associated with a decrease in symptomology, although some studies show that positive reactions might be more associated with some increase in problem-focused coping or social coping or less avoidance coping. Seeing this can kind of feel a little dispiriting because people feel, well, if I'm going to give positive reactions, why isn't it going to help? But in some ways, it's a little intuitive. If somebody's experienced a very large trauma and they're experiencing a lot of different symptoms, providing positive responses is important, but a necessary but not sufficient thing for decreasing their symptomology. The person still might need time to heal or might need treatment in order to help, but the positive reactions themselves are not going to decrease their symptoms. It's also important to realize that harmful impact can also come from good intent. So as I mentioned a minute ago, some negative reactions might be well-intended, but have negative impacts. And some of these are particularly more salient for mental health and other social service providers. So egocentric reactions, anything that takes really the focus off the survivor, what their current needs are. So a lot of times in healthcare systems, unfortunately, we have a lot of questions we need to ask, or the person may be discussing a lot of things, such as substance use and other things that may make people more want to focus on taking notes, getting through something quickly, taking really the focus off the survivor. Controlling reactions, a lot of times, again, in social systems, there are various reporting requirements and note requirements that need to happen. Even if people are kind of warned about that ahead of time, it might result in some situations which make decisions for the survivor that take away autonomy. And distraction. So anything really that tells somebody to distract or not to move or think of other things can be harmful. And additionally, even positive reactions and overtly positive reactions, including just empathy, reflective listening, a lot of things we think of as good, can be perceived as negative or even have a negative impact if the reaction is insufficient, so it doesn't really match someone's needs for where they're currently at, or if the relationship is not perceived as close enough. So some survivors report that though a mental health provider provided very positive reactions, they felt that it was kind of disproportionate and the person's showing a lot of empathy, but they don't have that close relationship to the person felt it just wasn't genuine or enough. So next I kind of want to give a poll to people, which negative reaction do you think is the most harmful for survivors of sexual assault? And the options you're going to be given are either egocentric reactions, so getting focused on your own reaction, taking the attention off them, distraction, trying to distract them, telling them to move on or not think about it, treating differently, stigmatizing them or treating them differently in some way, blaming them for their sexual assault or experience, or controlling, making decisions for them, not allowing them to make their own decisions. And I'll give a minute or so for people to respond. All right, looks like most people have responded. So you provide people kind of the results or let them see those. All right, so can everybody see the results? Okay. So what you see here is people kind of firmly came down that blaming reactions people will feel will be the most harmful. And that's what you commonly hear about. That's what I guess victim blame is one of the biggest things that we talk about. Then in a kind of distant second place are controlling reactions, and then some egocentric or treat differently reactions, and nobody put distraction down. So what does the literature show? So stop sharing those results for now. Thank you. So the literature that might come as a surprise to some people is studies show both cross-sectionally and longitudinally. As much as we talk about victim blame is definitely associated with negative reactions, including self-blame and increased PTSD symptoms, et cetera. It's actually not the most harmful reaction. Victim blame is a little farther down the list. And much higher up on the list is control, which is at the top, or making decisions, and distraction, or distracting, which nobody put down kind of as one of the big reasons. And so what's going on here that these ones are kind of, we'll go through in a minute, one of why these ones might be particularly harmful, and even ones that are as bad as victim blame seem like although it's harmful, that they don't have as negative an impact. And also this gets into why do positive reactions sometimes have negative effects. So we know that quality of support affects people's ability to cope, and that some of the most harmful outcomes come when people feel the cost of receiving that support, such as lower self-esteem or competence or perceived quality, outweigh the benefits. And if you remember, this kind of directly ties into some of those fears that people have, that it's possible that the cons will outweigh the pros. Secondly, notice that people notice behaviors that violate what they expect. So people expect their close friends and family members, and particularly social service providers and mental health, generally to give positive support to them. So even if a lot of that support is positive, if there's just one or two kind of people comments that are fairly negative or that question things, people are going to notice those. It's going to stick out to them. And negative reactions might be felt as betrayal to people who are expecting positive reactions. Also, we know that people internalize some negative beliefs, such as self-blame, if others are blaming them. Next, to go back to those fears, it's kind of a confirmation of their original beliefs that others won't provide help. So they start to kind of experience more distress that they're not going to be able to get help. We also know that even when people are trying to give positive things, the overprotection can cause depression, anxiety, and lower perceived control. Support might not match somebody's needs. And this kind of gets into the big one here, that reactions that fail to provide support don't provide coping skills and can even lead to more avoidance coping. So some thoughts behind this are that when people receive an overtly negative hostile reaction, such as victim blame, it's easier for someone to not internalize that because they perceive the person as being hostile. They perceive it as a fairly extreme reaction in some cases. However, when people are being told regularly, when control is taken away and people are being told either distracted, being told not to think about it, or told to move on, it's easier for them to both not only internalize that, but if they think that the person has their best interest at heart, that those kinds of responses can lead to them engaging in more avoidance coping. And that avoidance coping can have negative impacts on PTSD and other psychological symptoms. So what are some guidelines for supportive responses that we can provide and harmful responses to avoid? So the first thing we could consider is, what can we do before people even disclose? And one of the first things we could do is to really be mindful that people may have those fears of not being cared for, not being believed or helped, and being uncertain whether it's worth it. So we can keep that in mind as we're going to react, that we kind of have to encounter some of these internal fears that they have. People may also feel that they don't have a close enough relationship for the conversation. So although they disclose, and it might seem like, well, this person's kind of opened up this conversation here, they might not have a close enough relationship for the kind of conversation, and you may not be aware of exactly what they're looking for in that situation. As I said before, we should realize that as either friends or social service professionals, their expectations of our reactions might be higher, and they might be attuned to any negative reaction. So they're going to notice something. So while we're giving support, it's important to kind of pay attention to how they're responding and to realize that if we've provided anything that's kind of negative, even if we provided a lot of positive stuff, that we might want to follow up with it or to counter that again or to apologize for it or to somehow address it, because people be very attuned to negative reactions. Next is to make sure you have collaborations or contact with people and organizations that can help if you're not the best person to help. And it's particularly important to have resources available to respond to a diversity of people. So the literature that's out there, unfortunately, it's not as large a literature as you hope, but the literature out there trying to look at people across diverse demographics of people in all ways shows that some people really prefer to disclose and talk about these experiences with other people they feel is going to understand their demographic. And that's whether it's an age-related demographic or a racial ethnic demographic or based on ability status, because it feels like then the people might be able to understand more and they'll have less to explain about the situation. So that's all to say, we need to be humble and realistic with ourselves, and be realistic with yourself if whether you are the best person to help in this situation, even if you really want to help. And to decide kind of ahead of time how you're going to provide support if they are engaging in more maladaptive coping. So this is a particularly important one for really either community members or mental health providers, in that when we know the literature shows that you tend to provide more negative reactions if somebody is engaging in a maladaptive coping. So we know that's going to tend, unfortunately, to happen to us when someone responds to us. And for all those reasons I mentioned before, of not really knowing what to say if somebody has a lot of different things going on while they're disclosing to us. So it's kind of important to decide, particularly if you're a mental health provider and you might be providing referrals or want to follow up things later, to decide if somebody mentions using substances at the time, somebody mentions any behaviors you might consider harmful. If somebody's mentioning avoidance, are you going to talk about those behaviors at the time? Or are you going to follow up with them later? How are you going to talk about them in a way that might not accidentally increase the person feeling blame? How are you going to talk about it in a way that might be able to be positive in this situation? And also, if you need any referrals for anything related to these, how are you going to be able to refer them in a way that still makes it feel like you're going to be the person who's able to help them talk about their sexual assault experience. And also, as I said before, just realize being well-intended doesn't mean our reactions will not be harmful. So kind of to follow up with, to see people how the relationship has been, to follow up regularly with when you're talking to them, are you meeting their needs? And lastly, particularly for mental health professionals, to stay current on evidence-based practices in trauma-informed care and sexual assault in general, which I know everybody on this call is really trying to stay current, or if they're listening to a webinar, so that's great. Next is kind of how do we help those who are just considering disclosing? So a lot of times people, when they talk to us, they also mention that they're going to be trying to consider whether they want to tell another friend or a family member or a partner about assault, or if they're considering reporting to the police or a university or a healthcare system. So to talk to them about this and help them identify people that they know that might be more likely to provide positive support, kind of help them to understand and weigh the costs and benefits of disclosing. So as we said before, there's expectations. Those expectations are unrealistic or aren't being met, that could be particularly negative. So it's important for them to kind of realize what some of the costs and benefits might be of disclosing, and to provide that education about the potential impact of negative reactions so they know what to expect. And this is important because if somebody enters a situation where they tell their friend or family member or partner or police or anybody, and they get that negative response, it still might be harmful that they get that negative response. But if they know to expect it, then they still might feel that they have some control and meeting expectation over their own reactions, because they know what to do now. They know they might have experienced some distress and they have an idea of how they're going to respond. It also lets them kind of prepare for somebody's responding negatively that has nothing to do with them. That's the person might be responding negatively for their own reasons, and that can help them to avoid some of the internalization. Next, to help them with the distress from negative reactions, to realize that people who tell us about their experiences have also often had experiences of responding and of occasionally getting negative reactions, and may also then the distress from responding may be part of their overall experience to talk about, and identify whether any distorted cognitions are present in their perceptions. So the example I've given a couple times, if somebody thinks that nobody out there will really help them, or nobody's really going to believe them, and they have that fear, and then they finally disclose, and the people react in a way that kind of furthers this belief, then they might get an even larger belief that there's nobody out there, that and you're less likely to want to seek help, or less likely to believe that they can have help with any distress that they're experiencing. So if you're in a mental health profession, trying to identify those cognitions and respond to them can be really key. Also, to help them understand ways that others might be encouraging maladaptive coping and helping them to learn, engage in healthy coping. So it's important to try and talk through what have other people said in terms of particularly things that could lead to more avoidance and distraction, even if the people think they're trying to help, and to try and help them realize that those people might, if they disclose to someone new, again, provide those kind of reactions. So other research has looked at how to provide positive support, and this comes from both survivors and support providers, who tend to be in agreement of a lot of these things of how to provide the support. So first and foremost, people tend to say ensure survivors of the experience is not their fault, both to counter their internal blame they might feel and the blame that they might be getting from others, and just victim blame in general. To validate their experiences and counter those rape myths related to stereotypical rape. So people just to really validate whatever their experience is, and to realize that they might have They might believe others think there are different rate myths out there, or they might have internalized some of these rate myths and not feel that their experience is valid or worthy of services or talking about it. So to counter some of those. To show empathy, but to not show pity. To be an active listener and distraction-free, this is something a lot of people report, and it can be difficult, particularly for people in professional roles, to really do this, because sometimes the act of taking notes or the busyness of kind of the hour and other things can make people feel the person's distracted from a few things. To not attempt to save them or tell them everything's going to be okay. In general, people don't want false hope or somebody who tries to paint too unrealistic a picture of what's going to happen. Just being present, just to be with them and sit with them while they're talking about their experience. Acknowledge that healing takes time. So particularly also so they don't internalize any thoughts that maybe they should be over their experience by then. Acknowledge their agency and choices, yet avoid blaming them for choices. Survivors report that this one they know is likely hard for support providers, and they're kind of attuned to it. They want people to give them choices and acknowledge their agency and to give them things that could help them, yet they don't want to feel that they're being blamed if they don't make the choices that the support provider believes is the best or the most healthy, et cetera. And it is a hard needle to kind of thread. To check in regularly about their needs and expectations. So their needs and expectations might be very different at the beginning when they disclose than in the middle. You kind of individualize support to meet those needs. At some points, they may just want kind of more normalization, want somebody to talk to. It doesn't necessarily mean they're looking for kind of treatment for any distress or other things at the time, but their needs or expectations might change later. And also the reverse direction, they may have talked about it previously, but now are experiencing currently a lot of distress, want to not talk about it for a little while till they're ready again. Engaging in self-care. This is an important thing both for support providers themselves to obviously help self-care, but also really helps with providing support, because if somebody has not been engaging in self-care, they might be more likely to have a very large reaction, such as being overly upset or overly angry, which gets into those egocentric reactions, which can be harmful for survivors, or in their body language or presentation, seem like they're more focused on themselves than on the person disclosing. And on the other side of it, somebody who's not engaging in self-care could also be experiencing more burnout. And if they're experiencing more burnout, they might not be responding in a way that's adequately empathetic for the person disclosing. And again, just realize when you're not the best person to provide support, and that's okay. If you think that there are other people who might be able to provide support, that rather that you are realistic about where you're at with providing support, or if somebody else might be a better person to provide support. And providing options and having those resources available. Next, and some work Emily Dwork and all kind of have looked at is it's really important to set realistic expectations. So we know it looks like that people experience really a lot of negative impacts if their expectations, they have unrealistic expectations, or if they have expectations and people kind of let them down. So it's important, and as much as it is to assess their needs, to assess their hopes and expectations for talking at different points, because their expectations and hopes might change, to see what they're looking for and where they're at, and tailor responses when, if possible. Also to build and maintain rapport and comfort. So it looks like to keep that conversation going, rapport and comfort are really key, and that's rapport and comfort not just in the context of the person disclosing or talking about those things, but rapport and comfort in the whole relationship, so that they really feel that you're a person that they feel overall comfortable talking to. And to set realistic expectations for how you or others may respond, so they know that, again, that they're able to kind of prepare for it and able to realize that if somebody else responds negatively, then it's not about them. And similarly, in a treatment setting, if you think you're going to accidentally provide some of those egocentric or distracting responses because you need two different reporting, you have different things you need to do to set realistic expectations and to see what their needs are in those situations. And lastly, to be just overall honest and sensitive about situations where the reactions from others might not meet their expectations. And kind of lastly, more recently published an article that's, I think, a very useful article for kind of a framework for providing helpful reactions overall. Is more asked both therapists and survivors of sexual trauma to talk about what they thought were the kind of the most important effective elements of a therapeutic relationship. Also, I don't have up here, it's not the focus of today, but they also asked them about the kind of content of therapy and what is the most important elements of therapy, and there was agreement there, so I definitely recommend kind of checking it out. And there's a lot of agreement between survivors and therapists. One of the first things is to kind of counteract dehumanization. So a lot of people who have experienced sexual assault report feeling some dehumanization, of feeling objectified. And so things that can help the person really feel dignified, to basically make and keep space, to paying attention, to all those things of having them, helping them make decisions, to realize that their experience is valid and that they're a valid person with valid experiences, is kind of critical to counter some of that destigmatization. Next, kind of providing that non-judgmental empathy. Trust restoration, it's being a large thing as well. And again, that's trust not just in the context of somebody disclosing, but trust in the overall relationship. So maybe particularly important, although it's always good to try and build trust with people, maybe particularly important to make sure that you're staying good on your word, that you're making sure you're keeping appointments on time and not canceling last minute, and building up kind of trust if you say you're going to do something, or provide resources or other things to follow through with that, because their trust may be lost in other people due to both the experience and people giving them negative reactions. Next, breaking the silence tends to be a very beneficial thing for countering that stigma, and ending up just being willing to talk about it and make space for it, and showing that you have some experience to talk about it. And also kind of naming and normalizing it, that these are experiences many people have, and being willing to kind of normalize what the people are going through. Next, to free from self-blame. So they may have their own internalized self-blame, may have gotten messages from others. So really making sure that you're not only giving those messages of kind of that it's not their fault, but also making sure they realize where the accountability lies, with the people who perpetrated the assault, with the situations and institutions that may have betrayed them or responded negatively, et cetera. So they're not blaming themselves for the way that other people acted. Releasing from shame. Really, this gets into some of the ones above, of kind of making sure that you're normalizing and trying to lower self-blame, but also realizing that a lot of people who have experienced sexual assault have a prior trauma history. Particularly, it's common to have history of childhood experiences of physical or sexual abuse that are commonly accompanied with greater feelings of shame, to really try and create more self-blaming messages that are many messages that kind of counter that self-blame, and to try and normalize their experience, and to give them a space to talk about it and to let them know that it's not their fault. Next, what they called containment of the traumatic narrative. And this gets into the kind of the thing in the last slide we talked about, with just being present. So a lot of people feel that their trauma, there are a lot of, it can feel overwhelming at times with the amount of distress, the amount of things that have happened and experienced. So just creating a spot to kind of contain that narrative, to be reliable and stabilizing, so they know they have a spot where even when all this can feel very big that they can kind of have a space for it. And again, that stabilizing force also means it's important, as I said, to make sure that it's a spot that they can trust, that they can hold with you. Renewing that sense of control. So really, again, not just trying to maintain that sense of control regarding reporting the sexual assault itself, but also sense of control and throughout any decisions that you can help build up that sense of control with in your relationship with them. And you see that a lot of these past couple ones are directly countering some of that unsupportive kind of acknowledgement by being kind of a stabilizing force. That also means we're not engaging in that egocentric reaction, which means that we're kind of entering our own feelings and issues into the space. But that, and also that giving them that sense of control can kind of counter some of those controlling, the negative effects of kind of controlling behaviors. And lastly, to flex the boundaries, a lot of people, both therapists and survivors, agree that people might, who have experienced sexual assault, might require some more contact in therapy, and that it might require some flexing the boundaries. And the reason for this is partially because in order to be a stabilizing force, in order to kind of contain that traumatic narrative, in order to build that trust, it's important for people to realize that there's kind of a stable spot that they can, of somebody that they can go to and that they could talk about. So realizing that some of the typically therapeutic relationships may need to have some of those boundaries flexed in a slightly different way, and making decisions ahead of time about what those will be for you. So overall, all of these kind of combined can really help counter a lot of those negative reactions and provide positive alternatives in a therapeutic relationship. Yeah, that's all I have for you today. So thank you for coming today, and I would be happy to take kind of questions and comments, and I'll stop sharing the screen. So happy to take any comments if there are questions that people have.
Can I ask a question, Mark?
Sure, absolutely.
An interesting topic to me. I guess I don't know like how for like after sexual assault cases, like how often like they report quickly to hospitals and things like that. But like when like doctors triage with like clinicians, like what is like the optimal way to like for them to like start addressing like their issues so that like patients feel comfortable and like they take into account like the negative reaction that can come from that.
Yeah, it's a great question. I don't know if I totally have the knowledge to answer what's kind of the optimal way. I know what's kind of considered some of the best practice now is usually emergency rooms have people who are kind of the sexual assault nurse examiners, which is commonly combined with people from local rape crisis places and other places too. So they have kind of an advocate in that spot who can help them really manage the variety of questions and relationships and other things they're going to get there, primarily so that they can feel that they're able to make kind of informed decisions, that they're able to feel somewhat in control, et cetera. I don't know of that many, it may be out there and I'm not familiar with the literature, but I don't know how many studies have really examined these various ways of doing things empirically in terms of kind of long-term outcomes for long-term functioning. In qualitative research, people certainly have reported that it was helpful to them in terms of whether it lowers distress over time or is associated with better outcomes. I'm not sure either way.
Thank you.
Anyone would like to unmute, you can feel comfortable doing so. If you'd like to raise your hand, there are a variety of ways to get our attention, but I want to make sure that folks can ask any questions they might have.
Hi, I'm Tammy. Question about self-disclosure when working with victims. Is it better to or not to self-disclose that you have also been a victim at one point?
That is a great question. I don't know of kind of, again, similarly, the kind of quantitative what's best on average, which would probably be a little difficult to figure out because the amount that people self-disclose and the context of that relationship could obviously vary a lot and depend on the situation. People have talked about this a lot. I think that generally I've seen people say that they feel that as much as the self-disclosure really is only beneficial if it's going to further kind of normalize things for the person and have that positive impact, but has the potential in sexual assault cases to have that negative impact of kind of that egocentric reaction, which could be difficult to judge because the person just may not know how to respond if their mental health provider tells them that. On the other hand, I will say people do have reported it being both positive and negative in their own therapeutic relationships when somebody else, including a counselor, has disclosed that. So I don't think there's necessarily a right or wrong answer to that. I think it would likely be a situation in terms of I'm a community psychologist, I'm not a clinical psychologist. So in terms of like what people say are best guidelines for clinical psychologists, I'm not an expert in, but in terms of what people say is helpful to them, some people said it helpful and some people have said it's harmful.
Thank you.
Yeah, thank you so much for the question. And I should say also in relation to that comment too, relation to what I said earlier, it's always a good idea in a therapeutic relationship because we don't know whether, however we've been responding is positive or negative, how it's really being perceived. It's always good to check in occasionally to make sure that the people's needs are being met, to see if anything that we're currently doing is being perceived as more harmful or helpful, and to have those conversations, both to be accountable to ourselves and so we can kind of change direction to fit the needs of the person in the situation.
All right, Mark, I wanted to jump in here. My name is Lee. I'm the tech support coordinator for today's meeting, and wanted to thank you so much for speaking to folks, and that we are recording this, so this will be available on the MHTTC website, which I am happy to share with you all at the moment, so I can show you our current trainings and event calendar. So please feel free after this to, if you're interested, check out the next events that we have coming up with the MHTTC programs. Again, as Mark said, it is fantastic to be up to date and get all the information, and this is the place to do it. MHTTC provides a whole range of different topics, and you can go to the website and sign up just through that website, and highly recommend taking a look at what is coming up. You can filter by keywords, event types, you name it. And there's a lot of opportunities should you want to check those out. And then I'm also going to throw into the chat now the survey link to let us know how today's event went for you. We highly recommend. It's great for us to get feedback about how you thought today's event was, what kinds of ideas you have for future events that we could offer through MHTTC and other resources. And the I will check in on the slides. I'm getting a couple questions in the chat over there. So I will check in on that, but that will probably be in the follow-up email that we send out to folks who attended today's session, which will also include the links to where we're going to put the recording, etc. And then I'm also into the chat going to as well put in the link for that website that I just showed to you. And you can feel free to check out the training and then also any resources. And as for the certificate, I would check with, let's see, Graciela, do you mind letting me know what kind of certificate, if any, completion attendance that we offer today?
Yeah, sure. Thank you for the question. This presentation and the PowerPoint will be available tomorrow at the MHCC page. So please feel free to check in. And yes, you provide participation, certification for participation for this meeting today. You please send an email to C4. Vanessa, you just reply the email that we will get from us with the information about the PowerPoint and the link to watch this webinar again. Yeah, so thank you so very much. I would like to thank you all. Mark, you appreciate our work. Geraldine, appreciate our work, and Lee. So thank you very much. I hope you enjoyed this presentation as much as I did. And I hope see you soon. So in May, we are promoting another webinar to talk about this topic. Would like to just remind you that April is the awareness month for sexual assault. So we have a lot of good things coming soon. Please stay tuned. Have a great week. And thank you again.
Thank you.
Thank you, folks. I see a couple folks in the chat letting me know that they're having challenges reaching the site for the survey. So I also have set it so when this meeting ends, the survey will open up automatically on your browser. And if there are any issues, I will make sure that in our follow-up messaging that you are able to access that. If this link is currently giving you trouble, we will be on that. And again, send any of your thoughts to the email that I added into the chat box. That's for Vanessa, who handles MHTTC content. So again, thank you so much. And I hope you enjoy the 7 minutes we gave back to you in your day.
Thank you all.